if you, as we do, we analyze 7-alpha-hydroxycholesterol in the same chromatographic run as 27-hydroxycholesterol, then in case of untreated CTX, you have 20, 30, 40-fold increased levels of 7-alpha-hydroxycholesterol and very, very low 27-hydroxycholesterol. And this combination, I think, is gives an absolute certain diagnosis, while we do not believe that cholesterol overstand. What is your comment on that?
I do believe you're right. We used cholesterol since it was a retrospective study, and I do think that 27-hydroxycholesterol would be much better than cholesterol. Also, because if we hypothesize neonatal screening, we could catch also SPG5 patients who present with cholestatic jaundice, since they have very, very elevated, markedly elevated levels of 27-hydroxycholesterol, and that's true that the combination of classic pathway and alternative pathway metabolites allows a better diagnosis. I completely agree with you, Professor Björkman.
Yeah, you showed yourself in your slide that you had very, very low levels of 27.
Yeah, we have very low or absent levels, undetectable levels in many cases. We are aware that this is. I think I was thinking before when the colleague presented neonatal data, I was thinking that 27-hydroxycholesterol may be the best metabolite to predict the diagnosis.
I have another question. In some cases, you had patients with somewhat increased levels of C4, of 7-alpha-hydroxy-4-cholestyl after the treatment with chenodeoxycholic acid. And according to our opinion, that reflects that the patient does not get sufficient dose of chenodeoxycholic acid. And we use instead, in this case, 7-alpha-hydroxycholesterol as a marker. And if we find that the chenodeoxycholic acid does not press the levels down to the normal level, then we increase the dose. So in some patients we have increased the dose 3 times before we get a normal level of 7-alpha-hydroxycholesterol. So I think that one should consider to treat the patients harder if they do not reach the normal level of C4 or 7-alpha-hydroxycholesterol.
Yes, I do agree, because we have to use 7-alpha-C4 as a prognostic marker also, than a diagnostic marker. It's very, very, very important in order to adjust the dose of chenodeoxycholic acid. We are first performing this analysis now, and I think we'll have important information on treatment response, and I think that 7-alpha-C4, as you demonstrated, is much more important for pathogenesis of neurological damage than cholesterol, and it may be the right marker of treatment response. I agree with you. We'll do it.
Other question? Yes, Stefania?
Hello again. I have read that the LDL apheresis in this with the CDA combination therapy, in your opinion, maybe, I don't know if it's correct, if it's you or not, it doesn't work as Silke has told us. What do you think about this? Is just only one case? It's because because the Monet apheresis, or we should try? What do you think about Silke has told us? Thank you.
I think that I have the same question to Dr. Matisi, because in the literature, at least there are 3 cases that has been reported with apheresis. One by our group, from a Japanese group, and these patients. What is your opinion of the other report from the literature in using apheresis?
Yeah, actually, we can't compare because we have only this one patient, and maybe we are lucky, and it works with this patient. He is also administered with CTCA, as you saw on slide. Maybe we knew too less about the whole metabolism. This is an explanation I could drive, but in the end, we don't know why it should not work for the others. Maybe we are just lucky for this one, and it worked. It helped quite rapidly, as I told you. After the fourth apheresis, he recognized by himself that it's better. And what I've forgotten to say regarding the psychiatric distributions or disturbances, this appeared later. This appeared some months after this apheresis therapy, that he recognized that there's something wrong with him and what he missed in his life and what he will always miss. And then the depression came. This was quite interesting for us. Now he's better also from this point of view. Now actually we don't know. We can't compare. We have only this patient. And what we have to confess, this is quite expensive. It's a quite expensive therapy. He can tolerate this very much for the physical side, but it's an expensive therapy. Fortunately, the German health insurance system pays fully.
Yes.
So again on the apheresis, so what is your speculation on why is this working for the neuropsychiatric symptoms? What is happening in the brain? I mean, do you have any clue? Because it's not because of the effect on cholesterol. It's on the effect of what? It is perhaps just re-equilibrating, brain cholesterol homeostasis, or what is happening there? I know, speculating on it.
Yeah, perhaps we can speculate on the role of which is the toxic agent to the brain, and perhaps Professor Björken may help us because is 7-hydroxycholesterol the toxic metabolite to the brain more than cholesterol or other derivatives, which is the most toxic to the brain function metabolite in CTX?
Well, we have several evidence that 27-hydroxycholesterol in itself is a toxic agent, and that it has a lot of negative effect on the neuronal system, and that neurodegeneration increases if you increase the flux of 27-hydroxycholesterol into the brain. From that specific point of view, it would be an advantage to be a CTX patient. But then 27-hydroxycholesterol has also, we have shown that it is suppressing cholesterol synthesis. For example, in mice with a knockout of the 27-hydroxylase, the rate of synthesis of cholesterol in the brain increases. So it has some effects also on the general cholesterol homeostasis in the brain. But otherwise, I think that the accumulation of cholesterol in the brain is the most important pathological factor. And we also know that it's even possible to decrease the xanthomas in the brain by long-term treatment with chemo. So I think that is the most important pathogen.
And I think that we can interact with this metabolism also with statins. Do you think that statins may have some role in combination with chenodeoxycholic acid to change the metabolism of the brain and to help in the neurodegeneration stop progress?
Well, it's very difficult to get statins into the brain, and you have to use very high doses in order to.
But we have a change in the blood-brain barrier in such patients, so this may help the statin approach to the brain.
But if you treat the patients with chenodeoxycholic acid, I assume that the blood-brain barrier will
be restored.
Stop the leakage.
Yeah.
But there are some studies where chenodeoxycholic acid has been combined with statin treatment, and it's very difficult to say whether or not the statin has given any additional good effects. That has been claimed by some authors, but I doubt that it is that way. So the value of additional statin treatment, I think, is questionable.
Professor Björkman, can I become an asker for a moment?
Yeah.
What do you think about therapy if 27-hydroxycholesterol could be, the lack of 27-hydroxycholesterol could have a rule also on therapy, on new therapies for CTX by substituting 27-hydroxycholesterol? This could have a sense.
Well, in view of the fact that treatment with chenodeoxycholic acid removes all the symptoms. I mean, if you start treatment at an early age, the patients will not get any disease problems, as far as I know. I think this is rather theoretical. I don't think that would add anything.
Beneficial.
Susie?
So basically, it looks like we at this point we don't really exactly know why therapies work. I mean, right? We have lots of questions. We know that chenodeoxycholic acid lowers cholesterol and that improves symptoms, especially if treated early. But we don't exactly know why or what happens in the brain later on when it doesn't work as well. And we know that apheresis maybe sometimes can work, but we don't know exactly why. In all that speculation, would it make any sense to look at these metabolites, different metabolites in CSF? Would it help find out what is really the mechanism that is going on? Why, I mean, I know it's of course not so easy to do it, on a weekly basis, of course, but maybe, on a couple of months basis or even monthly basis, that's doable. I mean, would it make sense? Or?
I think from the ethical point of view, we can't.
You think so?
Yeah. Or maybe once, but monthly. Maybe once, but.
Yes, this is the problem of neonatal mass screening in this adult disease, and I will report you a beautiful article that was written by a French neurologist on Pompe disease, and he was affected by late onset Pompe disease. And he was a neurologist, and he wrote, "I am 50 years old and I am still waiting my disease, but from a genetical point of view, he was affected by Pompe disease." And this is a big problem of neonatal screening. So we can discover genetically affected patient, but not clinically affected patient in relationship to the clinical heterogeneity. And this is still true for Fabry disease or for many other diseases. Of course, there is a big debate in which there is a different approach by a pharmaceutical industry that would like to treat as soon all patients with very expensive disease, and the clinician that say we have to treat symptoms and not the possibility that but this is open problem. This is very old question. Yes, please.
Yes, I have a question for you all, also for Professor Bjorka. Can we learn more from the knockout mouse, because the knockout mouse has no neurological symptoms at all, and adult patients deteriorate despite CDCA treatment. Can we learn more about the mouse, from the mouse? Is the mouse sufficiently studied biochemically?
Unfortunately, the knockout mouse is not a very good model for CTX, and we believe that the reason for this is that in the mouse the most effective down regulator of bile acid synthesis is cholic acid or deoxycholic acid, whereas in man it's chenodeoxycholic acid, and that means that if we knock out CYP27 in the mouse, the increase in bile acid synthesis in 7-alpha hydroxylase activity will be about 3, 4, 5-fold, whereas in the human it's 20, 30-fold, and that means that there will be a much higher accumulation of bile acid intermediates, and we have considered different ways to modify the knockout model we have no good solution at present. I will give you some data in my lecture.
Other questions? We have 5 minutes more before lunch.
Hola, muy buenas. Encantada de escuchar a cada uno de ustedes y todos los que han participado. A ver, yo hablo desde el punto de vista de un familiar. Voy a aportar un poquito menos de técnica para un poco aportar la parte de los familiares que estamos aquí. Algunas preguntas sencillas. Yo tengo 2 familiares afectados, son hermanos de mi marido. Ellos empezaron el tratamiento con fenodesoxicólico desde hace ya por lo menos 25 años. Su progresión ha ido, imagino que lenta, no tengo comparativa, imagino que lenta pero progresiva, con un deterioro en la marcha, santoma, atasia, variabilidad clínica, ¿no? Quiero preguntar algo muy sencillo, y es lo siguiente. Yo al oír a la doctora hablar de la feresia he introducido algo en cuanto a dieta. Podemos aportar con datos objetivos y lógicos recomendaciones en la dieta de estos pacientes, en los cuales nosotros podamos disminuir los niveles de colesterol y así colestanol en sangre, y que podamos ayudar en la detección, en la evolución de los síntomas. Tengo una segunda pregunta muy diferente en relación a la detección del neonato, y apoyándonos en los estudios del Dr. Berry. Realmente en el neonato ya hay unos niveles de colesterol en sangre o metabolitos que nos puedan ayudar en el diagnóstico tan precoz, porque ahí no tenemos ningún síntoma, salvo que el Dr. Berry ha dicho que ha establecido diagnósticos de niños desde 0 a 20 años. ¿En qué momento estos niños han podido ser diagnosticados? Si es por datos clínicos o porque se le ha hecho la determinación de colesterol a niños tan pequeñitos. Gracias.
So I have understood that there are some problem with diet.
Yeah, well, so I can summarize
yes.
the 2 questions. They're very in summary. One of the questions is there anything regarding diet that could be done based on scientific data, any diet that can be recommended to reduce cholesterol and therefore the downstream route? And the second specific question was how were the youngest patients picked up because they had symptoms or through some screening protocol problem?
Perhaps Dr. Verrips may ask.
Two questions. So, who wants to answer?
Yes, Dr. Verrips.
Well, the younger patients were diagnosed, some of them because of the combination of premature cataracts and diarrhea. And with that diagnosis, the first two children with the diagnosis, 3 more affected SIPs were found. Some of the children were accidentally diagnosed. For example, that very young child with viral infection and convulsions, epilepsy, which made metabolic screening necessary, and therefore the diagnosis was made. And I have one patient, and that's a very peculiar case, in which the mother diagnosed her own son. And the mother is a psychologist, and her son had learning difficulties, behavioral difficulties, and chronic diarrhea with cataracts. And she did a literature search, and she emailed me and made a case history, and she said, no, doctor can diagnose my son, and I'm convinced that there must be something wrong, and perhaps he has CTX, and he did have CTX. So.
Yes, so
Thanks. So none of the cases was diagnosed through any type of screening? Perdón. Sorry, perdón. Ninguno de los pacientes se diagnosticó a través de un programa de cribado donde pues, de manera rutinaria todos se analizasen o todos los que cumplían ciertos criterios se analizaban. No tienen este programa establecido. Todos se diagnosticaron porque tenían algún tipo de síntomas. Cada caso fue distinto, o alguno un poco por casualidad, alguno era pues niños pequeñitos con diarrea y cataratas, y ahora estaba comentando uno que fue diagnosticado por su propia madre, que es psicóloga, y tenía un niño con problemas de aprendizaje, problemas de comportamiento, y luego el niño pues eventualmente tuvo diarreas y cataratas, y la madre le escribió y dijo, doctor Ferrips, creo que en mi niño hay algo que no le dan diagnosticado, he estado mirando y creo que podría ser CTX, ¿qué le parece? Y era. Entonces, que en respuesta a tu pregunta, pues por ahora yo creo que en ningún sitio está realmente establecido un programa de cribado con ciertos criterios, digamos, vamos a mirárselo a todos o a todos los que tengan X características, y esto es un poco lo que se está discutiendo y lo que creo que nos espera en el futuro próximo, decidir si podemos, si estamos en condiciones de plantear algún tipo de cribado, y un poco esto es lo que explicó en su charla el doctor Cocho, ¿no? Que para llegar ahí primero habrá que hacer una prueba de concepto o un estudio piloto cribando no a todos los neonatos, sino a lo mejor a algunos con ciertas características, pues por ejemplo hiperbilirubinemia o a niños con diarrea crónica y tal, y ver si ahí aparece, y luego pues bueno, pues extenderlo a otro tipo de cribado, pero eso por ahora no está establecido porque necesitamos estudiarlo entre todos más a fondo para saber lo que estamos haciendo, para estar seguros de que no tenemos un elevado número de falsos positivos, y esto es un poco lo que, ¿no? Resumo las dos, yo creo. So who wants to answer the question about diet? Is there anything
so there are no particular data from the literature related to diet and cerebrotendinous xanthomatosis. So on this moment, I think that the disease seems to be related to some toxic effect of several metabolites on the brain with the neurodegeneration, and it seems that we can lower these metabolites by drugs that are able to interact with the complex cholesterol cholesterol metabolites, or we can eliminate the metabolites by some apheresis of other technical possibility. And I think that in the future it would be very interesting to understand which metabolite is toxic to the brain function, and in conclusion this session, I think that we have some patients in which there is some capacity to regulate the efficacy of these toxic metabolites against the brain by a self-regulation, and this is in combination with therapy are good responders, and there are other patients that are protected by the capacity to detoxification and are bad responders. To understand these aspects, I think is the key of the future in order to have better therapy, and of course some genetic therapy to understand to the future for the better treatment of this patient. I think we can close the discussion on this topic, and we can have a lunch, I suppose.
Yes, I agree. So we will have more time for discussing later on anyway. So yeah, thank you so much to everyone, and let's go to have some lunch. We should be back by 3:30 or something like that. Yeah. Cool. So yeah, we'll see you all here at 3:30.
Potevo entregarlo a